So welcome to PHHP Days. My name is Dave Fuller. I'm the Associate Dean for Research here in the college. I'm just thrilled to welcome you to our pillar presentations today. I think we've set a attendance record for a PHHP Days event with just now when So it's just so great to see a packed auditorium. So students who are here, thank you for taking the time. To our guests from out of town, thank you for being here with us. We really appreciate it. To all the faculty, thanks for all the work you've done to support this event. To the staff, it wouldn't happen without you, so thank you so much for all you do. Now, what we're in for, so the pillars of the college. So the pillars are structures that are fundamental parts of a structure that hold it up. And so what we're going to hear about is the pillars of our college, what's holding up our college. So the things that we are here to do include teaching, research, clinical service, and then just service to our community, to our college, to our nation, to the world. And all of that is going to come together now in short talks presenting big ideas. The format is going to be, it's a 10-minute high-level overview, and then if we have time, we'll do a couple of questions and then move on to the next one. I'm absolutely thrilled to introduce our first pillar presenter, Dr. Sarah McKune, and she's going to tell us about why global health research matters, science and social justice. Dr. McKune, thank you for being here.
Thanks so much. You can hear me? I know it's 2 full days of hearing about public health and health professions, so it's a real honor to have a packed audience and have you listen to me for just a few minutes about global health research. I want to start, if I figure out how to do this, I'm going to start by, there we go. That's where we're headed, why global health research matters. But I'm going to start with a question that my mother-in-law asked me 25 years ago when I moved to Gainesville, Florida. And that was, why Africa? Why do you have to go to Africa? Public health is a problem right here in Gainesville, Florida. You don't have to go to Africa to do public health work. And while this caused some internal consternation, it also just prompted a lot of introspection on my part because, let's be honest, I love what I do. But the question of why, what was it about working in Africa that I love so much? And it's really the marriage of public health and social justice on a global scale. So let's unpack that. What do I mean by that? The core of it, I think all of you know what public health is, right? It's trying to prevent poor health outcomes in a population. It's what all of us do, either clinically, through research or service, even teaching. But the social justice piece is the part that gets me going. I was a French sociology major in college, and I fell in love with the social contract, this concept that we are bigger than the whole, but we buy into a social contract. And social justice is built on that idea that there are structures in the world we live in, physical, social, political structures that benefit some people and penalize others. And in the health sphere, what we see is that some people have better health outcomes. And we understand that in public health domestically. We talk about how that affects us here in this country. But globally, I have had the opportunity to see in low and middle income countries that this is a global phenomenon. This system that benefits some and not all from a health perspective, who has access to healthcare, it's a global phenomenon. So I had that privilege of understanding social justice on a widespread scale. Then the other piece of this is global health research. So how do you take that social justice, public health work and apply it globally, or why do you? So we're going to start with the definition. What is global health research? Global health comes out of a subset of public health that when I was in training was called international health. Now, international health focused on the health of people in those low middle income countries. So issues like infectious disease rates, diarrheal disease, maternal mortality. But by the end of the 1990s, beginning of the 2000s, it was very clear that international health is not disconnected from public health, right? We're all in this together, whether it's because of technology connectivity, travel connectivity, borders became porous. Conceptual borders, interdisciplinarity took off, but we needed global health research. And so global health research today is research that works with underrepresented populations globally to understand and address the disparities that occur in those areas. But by doing research in those places, we contribute to scientific knowledge that we all benefit from. That's the argument I'm making to you here today, the pitch I'm making to you. Some of you are the choir to whom I'm preaching. Others have their work situated here in the US, and I would argue we can take that globally, do global health research, and contribute to knowledge and innovation in a different way. So let's dive in. What are the contributions that global health research makes? What are those contributions? The first is global health research just simply advances scientific knowledge. Specifically, this happens in a couple of different ways. One is that by understanding diverse populations, asking the same questions in different places, you're working with different regional populations, you're working with different genetic bases, you're working with different environments, social factors, religion, beliefs, behaviors. All of those things drive the way disease happens. So when you look at specific diseases like malaria or tuberculosis, all of those things affect the way a disease manifests, well, how it's transmitted, how it manifests, how people experience their own symptomology, and certainly the progression of disease, right? It's built in that landscape. So by understanding it in different contexts, not only are we better able to meet those health needs, reducing the disparity, but we learn things along the way that propel things like precision medicine, our ability to tailor the way we treat individual patients globally, because we now have a broader understanding of that disease, pathogen, illness, outcome across contexts. Similarly, the way we do global health is through teamwork, and we work with local partners. And what that means is that you have diverse perspectives, asking the original question, identifying what is the problem we're trying to solve, how do we put a team together, what is our idea, what's our hypothesis. That collective diversity of perspectives and ideas that are coming from scientists in those contexts means that we do different work. Not only do we ask different questions, but we do our work differently and we do different work. So that diversity of perspective leads to innovation, which is the second major contribution, I would argue, global health research makes. So innovation. Global health research drives innovation. Arguments here are we get new technologies, right? New technologies through the questions and research and how and where it's being done, treatments as well. And then we get disruptive innovations. And we could talk a whole day about disruptive innovations. But let's go back. Treatments and technologies. When you seek to address that, when you investigate as a scientist vaccines or HIV, and you begin to look at it because it's a problem in a low-income country, in a middle-income country, in a disadvantaged population globally. Let's just leave it at that. You contribute to science and doing science and yield results and insights that have transformation far outside the spaces that you're asking the questions. So some of these new technologies and treatments come from antibiotic drug resistance, from malaria research, from vaccine research. HIV is one of the big ones because so much around immunosuppression and our understanding of that came from HIV research. So these are just a few examples where you get an interest in a global situation or problem that's happening in one space, but the transfer of knowledge and the innovation that happens is big. Perhaps one of the most important things that happens to drive innovation is that in global health research, it's hard, right? It's really hard. It's happening in a context of limited resources. By that, we're talking money, but we're also talking power. We're also talking water. We're also talking roads. We're talking about value chains, supply chains. Try running a BSL-3 lab in a low-income country. Many of you in the room know it's so hard to get reagents in to move. It doesn't happen easily or fast. And so you have to be creative. So some of the most creative, innovative, leapfrogging technologies in health have come from global health research. And I'll use the example of mobile health, right? There were no landlines across Africa from which information could transfer as the internet took off. But mobile phones changed everything. And so mobile health got its legs and was refined on the continent of Africa long before mobile health or mHealth was ubiquitous as it is today in high-income settings. So you see innovation happening that's transferable to the global north and to other places by doing global health research in these places. And the last argument I would make, the contribution that global health makes, is to social justice itself. And as someone who was initiated and baptized in the spirit of social justice, I think what I want to highlight here is that the way we do global health research is different than, well, it's distinct, maybe not different. Maybe it's the way you do your research too. But it is first and foremost with and for the communities that we serve. And so we go in and work with partners. And a huge piece of social justice is empowerment and agency, giving people who don't have voice. So how do we use research to do that? We work with our partners. We work with our partners to come up with questions, to estimate hypotheses, to test those hypotheses, to implement solutions, to test the solutions, and then we get out of the way, right? So that way of doing research is a huge piece of when you teach global health research, and when you do global health research, you're modeling a kind of equitable partnership in research that is at least distinct, if not unique, to that global health research space. So I want to take a minute to tell you about a trial that my lab has been working on that was funded by USAID and unfortunately terminated. But this trial was a pregnancy trial to look at reduction of malnutrition in kids in Rwanda. We know that the first 1,000 days of conception to 2 years of age are critical for child growth and development. We also know that eggs have a lot of magical properties that are really good because they're a high-quality protein, but they also have specific things that are really good for brain development. Increasingly, we're looking at the linkages between food and brain development across the world. We don't understand all of it. Many of you in the room understand it better than me. But eggs are a magical food. We know that, right? They're also available, and women control them in these low-income countries. So we developed and built in partnership over 3 years and then secured funding, a grant to directly observe pregnant women consuming 2 eggs a day to look at the impact on fetal growth and development physically and cognitively, and to follow those kids ideally over time. At the beginning, we were just following them for 6 months. I want to show you some pictures of that, there we go, trial. These are our trial manager. She's mobilizing the community. It's very hard to get women to antenatal care visits by 9 to 13 weeks of pregnancy, which was our goal. So you can see we were working with communities to mobilize women. We had to establish a value chain of getting eggs from the capital that were all safe and stable and the same kind every day into the rural areas where they were then prepared on site, hard-boiled daily, distributed by our team of food aid distributors to community health worker homes, where community health workers managed the eggs with the women in the control group. We then monitored the participants for their own health through pregnancy. By the way, you get women in ANC visits early, you improve health outcomes of mom and baby. So great example, we're trying to improve the lives of the participants while answering really important scientific questions, right? We have whole blood work analysis to look at everything from cortisol to biomarkers of nutrition, as well as to monitor cholesterol. So I use this little quick 2-minute vignette to simply say that research was important for 2 reasons. It was looking at a locally available tool to address malnutrition in a community where stunting rates among children, which increases all-cause mortality, it's a big deal, was over 30%. So we're trying to see whether there's a locally available tool to reduce malnutrition while simultaneously answering a really important question to the scientific community, which cannot be answered in an American context where dietary diversity is so high that you don't understand the impact of specific foods or food matrices on brain development. So all of that was really fast and a lot. But what I want to land on is that global health research is hard, but it's worth doing, right? It's definitely worth doing. It takes more time, it takes more money, but I would argue that the dividends are higher. We all benefit from global health research when it's done. Oh, I skipped one, sorry. Keep going. Don't stop doing what you're doing. If this is you and you exist in the space of global health, it's very easy right now to feel discouraged, right? To feel like what we're doing is under attack or not what's in vogue, whatever you want to call it. The need is it's not going to go away. The disparities are going to get bigger, And our place is there. We don't know what it's going to look like, but keep going. And for those of you in the audience who don't do global health but are interested in transferring what you do to a global sphere, come and find me, because there's plenty of work to do. And at the end of the day, I think it's the passion that we have for global health that keeps a lot of us going. With that, I'll stop.
Well, thank you, Dr. McKune. That was amazing. Time for a quick question or two? Got one in the back.
A great presentation. Disappointing to hear that your research was stopped, but can you leave us with, are there some positive things that maybe the relationships that you built, the infrastructure that you established that you think maybe is continuing, and hopefully the community still has a positive outcome, although you don't have the answers to your research questions? Can you talk a little bit about that?
Yeah, thanks for giving me the opportunity to answer that question. So piggybacking on what I was saying in the talk, if you do this the right way, right? If you do global health research, you've built partnerships, you've built infrastructure, you've built capacity, local capacity. And to illustrate that, I mean, we have had numerous, I can't count, meetings with UNICEF, World Food Program, the World Bank, the Minister of Health himself, as well as his team at the Ministry of Health in Rwanda. Everyone wants this study to continue. It's just a matter of trying to get the resources where they need to be to move things. And of course, the impact of the USAID cuts are not just on this trial, so it's happening not in isolation, but the whole landscape has changed. But there are a lot of hands on deck, and we have nurse sonographers trained who are ready to go back to the field, and that effort is underway, and we have UNICEF on board agreeing to continue the feeding of we stopped enrollment at the stop work order, but continuing to feed the children, and then with support from the college and other places, we are actually going to be able to go back and follow up on those births to try and get to preserve as much of the data. We had about 490 women enrolled at the time that we were terminated of a 950 study. So about half were enrolled. So we're trying to catch as much of that data as we can. As you said, we won't be able to answer the original questions, but we have a lot of data that can yield other research to come, and certainly trying to protect the participants that were in the original trial. So, yeah.
Wonderful. Well, thanks again. So I'm thrilled to introduce our next pillar presentation. Dr. Ashby Walker is going to talk to us about the community impact of public health research in diabetes. I guess as soon as we get the microphone, are you set?
This is going to dovetail really nicely on what you just heard about from my amazing colleague. I'm going to talk about diabetes. Diabetes affects so many people in our world today. It is a growing public health epidemic. The projections for where we're going to be with diabetes by 2050 is that 1.3 billion people in the world are going to be living with both type 1 and type 2 diabetes by that time period. The growth of diabetes has been so rapid, we have not been able to keep pace with the number of endocrinologists that we have in the United States that can provide care for people living with diabetes. For people living with both type 1 diabetes, which is an autoimmune disease, as well as type 2 diabetes, it's recommended that they see an endocrinologist 4 times a year for preventative care. This is really important. Diabetes is very hard to live with, especially for people that require insulin to live. In the United States right now, for every 1 endocrinologist, we have over 35,000 people with diagnosed diabetes that need to see that 1 endocrinologist. So what's happened in the United States is that the majority of diabetes care is actually being done by primary care providers. Over 90% of diabetes care, in fact, is done by primary care providers. The challenge with this is that oftentimes primary care providers are not the most up-to-date in terms of their knowledge on the best diabetes care practices. We've had major innovations in diabetes care management, For example, the introduction of technologies like continuous glucose monitors, but we still see tremendous disparities in terms of who's utilizing CGMs. And so really being able to empower and train primary care providers in the United States is one of our first things that we need to address as immediate concerns. There was a model called the ECHO model, Extension for Community Healthcare Outcomes. It was founded at the University of New Mexico, and the first iteration of this model actually was in hepatitis C management. There was a physician, Dr. Aurora, who saw a tremendous problem in his state where many people with hepatitis C did not see subspecialists, kind of similar to what I'm talking about in diabetes, but rather they were seen by community healthcare providers. So he envisioned and built a model where subspecialists train primary care providers through teleeducation to empower them to better do, in his case, hepatitis C management in the primary care setting. To be clear, the Project ECHO model is not telemedicine. You'll hear people say this, and I want you to know the difference. Telemedicine is when a provider renders care to an individual patient via something like Zoom. What this model is a provider-to-provider empowerment and training model. And by that, then you have an amplification of benefits to communities with diabetes, where one provider could see hundreds of patients living with diabetes. The way ECHO works is through what's called a hub and spoke model. A hub team of experts in some area of care train the primary care providers in 1-hour tele-ECHO sessions. In diabetes, what this looks like is adult and pediatric endocrinologist on the hub team, clinical health psychologist, social workers, pharmacy specialists, giving a 30-minute learning didactic on our field and best practices in diabetes care to the community providers who receive continuing medical education for attending. And then the second 30 minutes of that 1-hour session are an all-teach, all-learn de-identified case presentation. This model started in hepatitis C and is now being used all over the world to address those global challenges that we see in HIV, in Zika. In the United States, we had an ECHO post-COVID in nursing homes. While this model is being used all over the world, every little red dot you see is a Project ECHO program. And there are over 500 peer-reviewed publications on the use of this model. One of the challenges that we saw when we started working in this space is that almost all of those publications define the success of this program by whether or not a provider becomes more knowledgeable and confident in doing subspecialty care. However, the 500 publications didn't focus on whether or not that empowerment led to improved patient outcomes. Those are two really different questions. When we did a scoping review of all the publications on the Project ECHO model, another thing that was really lacking in those publications was any use of randomization. So while this is a really novel approach, we as public health professionals have to use rigorous scientific methods to be able to have evidence to guide policy and to inform decisions around implementations of things like this. I was able to work as part of a large multidisciplinary team here at the University of Florida. The grant we received and the project we did was a Project ECHO program. And we really wanted to evaluate whether or not implementation of this model could indeed improve patient-level outcomes and reduce health disparities. This is so important in the field of diabetes. At UF, I was one of the PIs along with Dr. Michael Haller, who's in pediatric endocrinology. At Stanford University, our partner on this grant, we had Dr. David Ma, who is an MD, he's an endocrinologist, he's also an epidemiologist, and our clinical directors were Dr. Ananta Adala and Dr. Rayhan Lal. I'm gonna come back to this point at the conclusion of my brief time with you, but I want you to look at the amazing team of collaborators we had to build this intervention and then also to evaluate whether or not we were really able to improve patient-level outcomes. Every single person that you see highlighted in yellow has a background in training or they're in public health. We could not have done this project without the amazing clinical expertise that were on the project in terms of endocrinologists, diabetes care educators. We also couldn't have done the project without these large multidisciplinary teams that were trained in public health. For our iteration and implementation of this, we recruited 20 federally qualified health centers across California and Florida. We use what's called a stepped wedge design. So in a trial, if you're using a stepped wedge design, the FQHCs, the health centers that were participating, had randomized start dates. They came into the program in 6 months phased entry. But by using that technique of randomization and using a stepped wedge design, we were really trying to contribute to the larger scientific literature on whether or not this implementation model actually works. We rigorously evaluated patient level, provider level, and health center level outcomes. The FQHC in the United States is such an important site of care delivery. 30 million people receive their care at FQHCs. The FQHC cannot turn anybody away for care based on their ability to pay. They have to offer care based on a sliding scale in terms of someone's ability to pay. And one of the other things that's really powerful about the FQHC model is the demographics of their providers have to match the demographics of the communities that they serve within the medically underserved area. In all, across the 20 FQHCs in California and Florida, we had a cohort of over 32,000 adults with type 1 and type 2 diabetes that were part of our analysis. The implementation model we used the classic provider education. The dosing of this intervention was 6 months. The FQHC providers would come on to our tele-echo sessions twice a month. We also offered them access to what we called a diabetes support coach, which was really a combination of a peer mentor and a community health worker that was embedded within the FQHC. They had real-time support with complex medical decision-making with our hub teams, and then also they had access to an online repository of lots of diabetes care materials for the primary care provider. We had so much data being collected for this grant. In terms of patient-level data, we had surveys that were going on within the FQHC setting. We took very purposeful steps to make sure we were working to be able to represent historically underrepresented communities with diabetes that often aren't in our studies. We had provider-level data that we collected, and then we had the health center spoke aggregate-level data collection too. The main findings from our ECHO stepped wedge trial in this large collaboration between the University of Florida and Stanford University was that yes, ECHO diabetes can be used to help improve health outcomes for people. Pre and post intervention, there was a statistically significant reduction in the proportion of people within the FQHC that were greater than 9% HbA1c, which is a very important metric of health outcomes. We also saw a statistically significant improvement in the use of continuous glucose monitors and insulin pumps in the FQHC setting. There were many other outcomes we looked at, like diabetes distress, that also improved because of the provider's participation in the program. So the question I just answered with that, yes, we were able to evaluate systematically and rigorously that patient-level outcomes can improve with this provider empowerment model. I want you to know that this particular model is being used and can be used to do so many things to reach communities beyond the University of Florida and all over the world. In closing, what I want to circle back to was that slide that I had all the little yellow highlights of all the people in this project that had backgrounds in public health. We had biostatisticians on this project that were instrumental. We had spatial geographers. We had amazing people like Dr. Sarah Weston, a clinical health psychologist in our own college. We had health economists, health services researchers like me. And it took every bit of our knowledge collectively to be able to systematically and rigorously evaluate ECHO and to contribute to the larger science on this. For the students in this room today, wherever you are, I want you to know that you have chosen wisely. We need you right now. Public health prepares you uniquely to be able to do rigorous scientific evaluation, which is critical. Science and rigorous science is critical to being able to drive the decisions that we need to make related to policy. I also want to say that public health uniquely equips you to be able to work with underserved populations and build community partnerships. Thank you so much for letting me have a little bit of your day to share about ECHO diabetes. And with that, I'm happy to take any questions.
Thank you. That was a great talk. And as I'm a faculty in IFAS where we use extension and the idea of training the trainer all the time. And I understand that this is training health professionals, but I wonder if you've thought about using the IFAS extension army that there is to sort of extend this then into the public.
Well, absolutely. So beyond the 64 sites we're already working with in the state of Florida in our FQHCs, I have the honor of working with Dr. LaToya O'Neill from IFAS, and we are currently trying to extend the diabetes support coach arm of this into your extension offices. So we are operating in the same circles for sure, and there's some really rich collaborations ongoing there.
Thank you once again. All right, I'm very excited to introduce Dr. Anna Galloway. We're going to hear about the ripple effect of how clinical experiences influence the classroom. So thank you for doing this. Welcome.
Thank you so much. So I am a clinical assistant professor in the Department of Occupational Therapy, and I want to tell you a little bit about what OT is. So OT, our goal is to get people back to the things they want to and need to do in their daily lives. These things that they do are their activities, which are also called occupations, which is anything that occupies your time. So that could be dressing, grooming, bathing, driving, medication management, all of the things that you need to do in order to function. So I want you all to practice being an OT for a second. It's harder than it looks. So let's say you're seeing a client who recently had a stroke. They have decreased strength, left-sided deficits, they have decreased cognitive attention, decreased balance, and you're trying to choose which intervention you want to focus on. Are you going to choose dressing or are you going to choose cooking? So I want you to raise your hand if you choose dressing. Now raise your hand if you choose cooking. And raise your hand if you're here for a good time, you have no idea. Excellent. So making a choice is the easy part. But in OT, our answer is always, it depends. Thank you, OT students. It always depends. It depends. What level of safety awareness does our client have? It depends. Do they have a caregiver at home that's willing to help them? It depends what their previous level of function was. Did they ever do these occupations before their injury or diagnosis? It depends what is important to them. And in OT, we are always applying our occupations into the client's real-world context, where we are working on skills like motor, process, and social interaction skills to get them back to whatever level of function is their end goal. So I presented a case study pretty similar to this to our adult rehabilitation lab course, and I was walking around listening to students create their interventions. Their case had many more details than what I provided to you. And I overheard two students having a really unique interaction. One student said, "Why did you choose cooking?" And the second student said, "Because it felt like the right answer." We've all been there. And the first student said, "But why not dressing? How could that better meet the client's needs?" And it was in that moment that I realized something bigger was happening. The first student who was prompting this deeper level of clinical thinking and this prompting the second student to justify their clinical decision. They were not only a peer, but also a student on our OT Equal Access Clinic board. So in addition to teaching, I serve as the faculty coordinator for the Occupational Therapy Equal Access Clinic. This is a student-run clinic, meaning students run the operation of the clinic. It is faculty supported, meaning our clinical faculty provide supervision and coach our students in how to provide care. It is pro bono, meaning that it is free and it is a service to our community. And we are looking to give and provide services to people who do not have access to care. So our number one priority and our primary mission is to provide high quality care that is equal to what they would find in a traditional clinic. The byproduct of this is student learning. So we do not want to decrease the quality level because that is what we are trying to do. That is the mission of our clinic. So we do have some challenges. We have a cohort of nearly 60 students every year. We have decreased or limited physical space, and we have a fluctuating caseload, and we never know how many people are going to be on this caseload around the year. So what we do have is we created a sustainable and feasible model where we currently have 6 students who serve on this EAC board. Those students serve for a year for their semester 3, 4, and 5, and then they leave on their clinical rotations during semester 6. So the main challenge that our student boards have, our board members have, is that one, they are students in the classroom where they are learning new skills. The other challenge is they are trainees in the clinic where they are being trained on how to provide clinical care. And this is kind of a unique tension where they're learning things but also doing things, and they're trying to combine those and link those together. That makes it a pretty difficult role to be in. So we intentionally aligned our clinic and our clinic expectations with the curriculum that the students are in. So what that means is as students are building more skills in the classroom, they're taking on more roles and responsibilities in the clinic. So the idea is that during their very first semester of being in the clinic, they're providing about 25% of each case session or each clinical session. And by the end of their year rotation, they're getting closer to that 75 to 100% because they've built those skills and scaffolded into providing care. So in our curriculum, we embed groups. We love groups. I'm sure my students love groups. We have lots of group and team-based activities because we are mirroring and mimicking what our healthcare teams will look like in the future. So having the skills to work on a team is extremely important. Every person who comes into a group comes with their own knowledge base, their own past experiences, and those experiences impact how we solve problems. Now, when we are on a healthcare team, all of us have our own unique lens, our own unique way of solving problems within our lens, and collaboratively, when we are together and integrating together, we should be coming up with innovative solutions for our individual clients. So, sorry, I just got choked. So, as we are looking forward to how we design these groups in our program, we're going to talk today now about how these student clinicians impacted the group facilitation that we had in our lab courses. So we saw these students interacting in class. We saw them kind of facilitating this deeper level of thinking with their peers, and we started wondering, is something bigger happening? So what we did is we designed a mixed method sequential explanatory study, and we divided our 54 students in that cohort into 3 main student groups. We had board members, lab peers of a board member, and the non-lab peers of a board member. And you can see my beautiful people. This was really fun to make. So we have 6 groups where we had a board member and 3 that did not. And we just wanted to see what was happening naturally in the classroom and see how those clinical experiences might impact the rest of the cohort. These lab groups stayed the same for the entire fall semester during the adult rehabilitation lab course. This was fall of year 2. And at the end, we administered a 19-item survey measuring their confidence levels related to OT skills, to their OT process and clinical reasoning. And what we found was that board members did rate their confidence level higher, but only 4 items had significant differences between board members' confidence and their non-lab peers. That's only 4 of 19 items. And those 4 items were using and choosing theories, adapting treatment plans when new information is presented, conducting evaluations, and knowing when a client is appropriate for discharge. But that leaves 15 others that had no significant difference. And so now we're wondering what's happening in the classroom to contribute to no difference for these other 15 items. So we followed this up with a focus group, 1 for each of our student types. And what we did find was that the way these 3 different student types talked about clinical reasoning, self-reflection, and the OT process was very different. So let's first look at the non-lab peer of a board member. What we saw was more of this confined, they were very much bound by rules and structure in order to solve problems. So we saw this earlier advanced clinical reasoning stage here. They had a perspective that was mostly confined to the classroom. And what we also saw was that their responses focused largely on how the classroom structure and the group dynamics impacted them individually and had less linkage to what was happening in the classroom and how that would impact them in the future as clinicians. So it was a very interesting finding. We also saw that when they approached ill-structured problems, they tended to go with more of a divide and conquer approach rather than engaging collaboratively in their small groups. Now, when we looked at the lab peer of a board member, this is the group we really want to see, are they being impacted? We did see that they were positively impacted by their proximity to that board member. So we saw that they actually looked at the board members as leaders and mentors of their group. They were very open to feedback from them. They also started to build more self-awareness of their own critical thinking and clinical reasoning level compared to their board members. Instead of being intimidated by this, they were motivated to figure out how to get to that level. So they saw proficiency and competency in these board members and wanted to be there too. They also started to make more of the classroom connections because of what the board members brought into their labs. So now let's look at the board members. We expect them to have more skills because they've been in the clinic. So what they did was not only did they bring in their knowledge and their experience, but they used it in a very positive way in the classroom. So they demonstrated a deeper level of understanding. They had a deeper proficiency where they were okay with ambiguity. They were flexible and adaptable, and they leaned in with more confidence. But they also built this awareness to where they started stepping back and not short-circuiting their peers' learning. So what they actually did was let their peers grapple with the uncertainty, let their peers become uncomfortable with not knowing the answer, and then helped by giving guiding questions and promoting self-reflection. So they also kind of became extensions of our clinical faculty. So they were modeling some of the same skills that clinical faculty would use in the clinic. So not only did the board members bring our students up with them, they also impacted the class in so many positive ways. So our investment in the board members had a big impact. They emerged as clinical leaders. They also shared their clinical experience and were connecting things learned in the classroom to what they're seeing in the clinic. I would often hear them say, oh, we saw this in the clinic last week. I didn't know that's why we did this. Or, oh, maybe the thing we're learning today will be helpful in 2 weeks with this other client who's coming back for a service. So now that we have this deeper understanding of how this small-scale clinical experience impacted the peers, we can start to think about how we can intentionally design this to further impact learning communities. So looking forward, we are already kind of creating some new ways of how we'll implement this over the next board term, which is starting soon. We want to build it to where more students are in that yellow group where they are lab peers. So we could start to rotate our board members around the groups in the classroom so there's more exposure to them in these labs. We also want to think about how we can intentionally train these board members to have leadership and mentorship skills, so kind of training the trainer, but also mentoring the mentor, so teaching them how to support their peers as they learn and grow. Some other ideas are to think about how to embed this into other frameworks such as cognitive apprenticeship or in communities of practice to have bigger impact and maximize the impact in the classroom. And we also recognize that this is a unique structure to the clinical setting where we have it scaffolded along with the program and with what they're learning in the classroom. So the idea of expanding this to other healthcare professions, but also interprofessional education opportunities could have a bigger impact on healthcare education. So with that, that's not me. There we go.
All right, you know the drill. We've got time for 1 or 2 questions. I think Tinu.
Thank you for sharing. That was very interesting and very enlightening. Can you comment, please, on how you planned this? Like, was it a study? Was it something departmental? How did you choose the board members? You know, just a bit about the background of the planning that went into this.
Yeah, that's a great
Were
question.
the students aware that they were being studied? You know, can you just give a bit more insight about that?
Yes, absolutely. So the when we conducted this in that semester, the students knew what we were doing. We told them ahead of time, and they consented to the study as well. For the board members, we go through an interview, an application interview process. And the reason why we don't have all students in the clinic is because not all students want to be in the clinic. Some students don't have the same buy-in, but we also want to make sure that we are not decreasing quality. So while we had to kind of scale down some of our clinical operations in order to get to this like root way of how we want to perform our clinical experience, we hope to expand it so that there are more students involved in the future.
All right, our final pillar presentation for this afternoon is from Dr. Michael Marsiske, and we're going to continue the theme of research and education, and he's going to talk about the PHHP Teaching Collaborative. So, Dr. Marsiske.
Hi there. Nice to see you, Lenny. Familiar faces. Hello. So, can I start by asking you a question? Let's say, no, it's not a stats test. Let's say that you have, you're called to a meeting with your dean, and your dean proposes a radical change in the way you do some important part of your work. And you're sitting in this meeting and you're thinking, I'm not sure I have the time for this. I don't even know what the payoff would be. And your face starts to betray your inner monologue, and maybe even you stumblingly start to say something, and the dean turns to you and says, don't let the tail wag the dog. Visions from your values and beliefs and principles, and not let immediate circumstances determine. So what do? Well, if you're like me, you take a breath and you listen, and you open yourself up to the experience and see where it leads. So what was this radical idea? Inspired by the Pew Research Center 2011 report on how the digital revolution affects education, convened a task force, which came to be called the Blended Learning Task Force, to look at ways of imbuing the college with a future focus, finding ways to incorporate more digital tools with traditional face-to-face instruction, with the long-term goal of both improving students' learning and having the college's teaching be more based on educational scholarship. So today, I'm going to talk to you briefly about the journey that this particular conversation took. Formed my work, connected me with a community of like-minded scholars in the college that I hadn't reached out to from a research mindset, and it opened me up to thinking very differently about my teaching. So the task force initially convened experiment. It included representatives from each of the departments in a college, and they ranged from researchers to experienced instructors. Some of them like George Hack and Jimmy Pomeranz and Mark Bishop and others. And as we explored the mission that the dean had laid out for us, we sort of took away a couple of key ideas. And the first is that the traditional lecture, like this, no matter how interactive it is a one-directional communication of information. It's sage on the stage, and it's a limited information flow. Secondly, active learning, where students solve problems using course content, can elevate knowledge to levels of Bloom's taxonomy. Third, shifting didactic from the classroom to digital tools means and it uses that precious class time to be more interactive, engaged, and problem. The instructor shifts to the guide on the side, really facilitating student interactions with material. In this context, need to be transformed for online learning. In the best case scenario, shorter, snappier, fewer of these ums. It puts a really high premium on student preparation. They have to come to class prepared so that they can work on problems. This is often the weakest link of this approach, and it can affect approach which we think of as flipped or blended or hybrid learning is one that really guided our I believe, the fruits of this to this day. So for example, just in the recent past, Dean Vernig and the college have committed to upgraded facilities for the recording of presentation, increased investments in instructional design and instructional technology, sort of every semester acknowledgement of superior teaching has done wonders for morale among faculty. So that focus on teaching remains. The long tail of the blended learning committee, to sort of overuse the metaphor, is still elevating, I believe, teaching in the college. So for me, as an instructor, it accomplished something more. I've always identified primarily as a study cognitive aging and intervention. And in graduate school, my sole exposure to instructional training was a member of my committee who just sort of wagged his finger and said, teaching takes as much time as you give it, be sure to rein it in. Okay? The blended learning collaboration in that context was different. Suddenly in weekly meetings, we were empowered to talk about instruction, to explore technology tools with one another, share tips, share continuing education, try out ideas with one another, and it was a protected venue to do that. And fostered the discussion of teaching. And so this is my first big point. Teaching, it thrives when it is an individual endeavor, but when it is valued by the... And I believe the college does this in many ways, and I would actually hope the college might think about reinvigorating the teaching collaborative. It was so fundamental when teachers work together to solve a problem. So now what? So into 2013, and what we've caught fire, right? We've accepted the idea. I'm recording lectures. I'm doing mastery quizzes. I have small groups in class. How do I know, if it's working? Is all this effort to transform teaching having any positive effects in my primarily statistics classes? And my approach to evaluating that question is as a researcher. And for me, that means I try to measure successes and failures and use that to fuel changes I make in my teaching. I need to act like a scientist. So what does that mean? Succinctly, I think it comes down to making and testing hypotheses, measuring outcomes, making data-informed changes, and testing again. And not only does that sort of give me, I believe, a basis for my teaching practices, but it makes the whole thing more fun for me. Because what do researchers like more than seeing whether their hypotheses panned out or not? And so how does that work for me? Well, I created a teaching dashboard where I sort of all the micro changes I make year by year. Why? I keep a separate teacher's journal, interventions, changes to my teaching, and that's inspired by my colleagues on the Blended Learning Task Force. It's also a place where I sort of work out like a lab manual, the changes I plan to make. And so what that enables me to do as part of the dashboard is, for example, look at student evaluations of satisfaction with teaching. For example, on the left, the switch between the red and the green represented a switch from face-to-face to blended learning. Over on the far right, a little less optimistic, it allowed me to evaluate the effects of a switch from a GUI-based statistical analysis program, SPSS, to a more modern program language, R. More on that in a minute. It also enabled me to take all the comments that students make and run them through text analysis and sentiment analysis, and get a sense of both themes and also the global evaluation based on the kinds of comments students make. And this was important. It showed a similar kind of dip when we switched to R, and it gave me convergent validity, a thing a scientist would think about. Of course, you also want to look at performance. I looked at students' ability to do application of statistical knowledge to just pick the right analyses for design. And here too, we seem to see a bit of a dip. But I could use that information to do more scaffolding. I need to do more instruction and application. And at the last measurement, it looks like a little rebound. Will it continue? We'll know soon. Even on traditional concept learning, as measured with a multiple choice exam, by maintaining a reasonably stable time, and again, made adjustments as I saw dips in performance, and hopefully we'll see if the rebound continues. But hey, there's one thing about this that a scientist will hate, because what it is not possible to do in this kind of a setting is to infer causes. For example, those dips on the right side of the graph occurred as a global pandemic was happening, and I was changing programming language, and we were shifting in-person problem solving to an online environment. So you don't know causes, but you do know what's changed, and it gives you vigilance and motive to try things out and see if you can make things better. Those student comments help. So the takeaway for me then is two main ideas. First, there's great power in creating a collaborative teaching culture and a collaborative group of faculty that can work together and encourage each other. And second, approaching teaching like a scientist is a way both to make it fun for yourself and also to use data-informed decision-making as you change your teaching. So in closing, I want to say that I'm grateful to the college for many things, but it has been a remarkable environment for me in which to grow and evaluate and find new parts of my professional identity as a scientist teacher, and I hope it does the same for you. Thank you.
Hi, thank you for that presentation. The research you presented, did you kind of conduct that in isolation slowly with your classes, or were you able to kind of compare those changes in teaching instruction and methods to the same classes that are potentially taught by other professors in the department?
Yeah, so I did have comparison groups, but again, sort of opportunistic. We collect data on things like evaluations for every class and every college, so I could definitely look at the trends that were occurring in my classes as compared to the rest of the college. So take, for example, those reductions in sentiment and morale. They did go down across the board for many of our classes, but for mine they went down more. And so I could evaluate whether the dip was relative to the rest of the college or something unique.
What was the p-value on that dip of the... Any other questions for Dr. Marsiske? No? Well, thank you so much. So a couple of brief closing announcements. Well, but first we should recap, if I can do this. So we heard about the incredible need and importance of global health research in a really inspiring way. We heard about the ECHO program and how that can be implemented to improve diabetes care. We next heard about how the answer or the question in OT is always, yeah, I didn't know that, so now I do. No, and how the occupational therapy equal access clinic has really been leveraged to learn more about effective teaching strategies. And then lastly, just the power of the teaching collective and how bringing science into the way you think about your teaching can be transformative. So please join me in thanking 4 amazing speakers again. Thank you. And a couple things. So lunch is available on your way out. There'll be a sign telling you if you want to grab a sandwich. That would be great. Please take a moment to stop by some posters and make somebody's day, right? Talk up a student, let them tell you about their work. And finally, I hope to see you all at the reception, which will be 5 o'clock over in the Basic Science Building, which I think is right there. So on your way out of work, stop by. We're going to be doing an awards ceremony at 5:30. If you can stay till then, that'd be wonderful. Enjoy the rest of your day.